Fantastic. So welcome everyone to our live Q&A on nephrectomy. And I'm just going to share a couple of slides to start us off. Hopefully you can all see those. Susan, are they visible?
They're not on my screen at the moment. I'm too busy going round everyone that's in the room, making sure we're all in quiet there. Nothing coming up. Is anything else? James, are you saying, Nick?
Give me a second. I just rebooted my computer before I started, so that's probably why. Right.
Sure.
Okay, great.
Perfect.
So welcome everybody. And I'm particularly delighted today to introduce to you our two speakers for this session, Mr. Nicholas Inston and Mr. James Barnes, who are both consultant renal surgeons at the Queen Elizabeth Hospital in Birmingham. For those of you who might have attended a Birmingham in-person event in the past, you might recognise Nick, who's often turned up and given us a talk about transplant in general. But this session is going to be focusing on nephrectomy because we know it's a topic of interest to many of us with PKD. So just to introduce the PKD team on the call, so I'm Tess, the CEO, and I have actually recently had a nephrectomy just over 4 weeks ago. So I'm very happy on this call in the Q&A session to answer any questions you have relating to my personal experience of going through nephrectomy. And we have Susan, our support manager, who's been liaising with you all. So just to remind you that we are recording the session, and it will be uploaded to our YouTube channel. Stay on mute with the video off during the presentation. And then when we come to the question and answer session, you can of course use the chat and put your question in there in text form. But if you do want to ask a question live, just put your hand up, we'll notice you, and you have the choice then of either staying with your video off or putting your video on. Some people are happy to put the video on, but you're more than welcome not to. And then I would like to thank you also for your questions in advance. You've been very helpful. We're very grateful to the National Lottery Community Fund for enabling us to hold these sessions. They've been supporting us now for the past 3 years and enabling us to continue this support work and educational meetings. And then finally, this meeting and session is for information only. And it's not going to be a substitute for professional medical advice or examination. No, any specific questions relating to your own care cannot be answered. And you must always consult your own doctor or other medical professional if you've got any concerns at all about your care or before taking any treatments. And we're not recommending promoting any particular treatment or brand. So for those of you who may have just joined, just to remind you that we have two fantastic speakers on today. We've got Mr. Nicholas Inston and Mr. James Barnes. And James is going to share his slides when I stop sharing now.
Can you see that?
Perfect.
Excellent. Good afternoon, everyone. Thank you very much for the invitation and the introduction. As Tess said, my name is James Barnes. I'm joined by my colleague Nick Inston. We're both surgeons at the QE in Birmingham with significant experience of polycystic kidney disease and nephrectomy. And so the remit given to me was a 20-minute talk on polycystic nephrectomy. And we're going to cover why we do nephrectomy in polycystic kidney disease, things that we consider in combination with you, the patients, techniques for polycystic nephrectomy, spend a bit of time about what can go wrong and the risks and complications that we discuss, general recovery after nephrectomy, and then a Q&A session at the end. And you have shared a lot of questions with us, which will try and hopefully I've covered most of them in the discussion. There's the common themes, but we'll try and go through some of them afterwards and make it a sort of informal discussion and debate. Happy to answer questions as we go along. So anything particularly pressing, then please Tess or Susan interrupt, but otherwise I'll keep going through the slides. I'm specifically not going to cover medical therapy of polycystic kidney disease. So there's a drug which many people are familiar with called tolvaptan, which can slow the progression of renal failure and polycystic disease progression. I'm not going to talk about kidney transplantation. I'm not going to talk about polycystic disease in other organs other than the kidneys. So as I'm sure you as an audience are very familiar with, polycystic kidney disease is a cystic degenerative condition. So you get multiple thin-walled sacs filled with fluid within the kidneys that start off very, very small, and some of them can become very, very large over time. It's a genetic condition, meaning in most people it's inherited, and most of the time it's the dominant form, which means you only need one copy of a gene from your parents rather than both. And there is another form of recessive form, which is more severe and presents younger in life, but I'm not going to go into that side of things. It accounts for approximately 10% of all renal disease that we see in secondary care, though it is quite rare. 1 in 1,000 to 1 in 2,500 people in the UK will have this disease. But what does that mean in reality? So what it means in reality to you is that your kidneys get bigger over time, and sometimes it does affect other organs, the liver, pancreas, spleen particularly. Treatment isn't normally needed for the polycystic kidneys, certainly not surgical treatment, until you get to the end of the renal, what's called end-stage renal failure, where the kidneys aren't functioning properly anymore, and we need to start thinking about replacing the normal functions of the kidney. And that's called renal replacement therapy, and it, broadly speaking, consists of either dialysis or a transplant. And again, I'm not going to go any further information about those today. So looking at the symptoms and signs, so the history, what we ask you when you come to see us in clinic is, what actual problems are these kidneys causing? One of the predominant symptoms is pain. Normally people complain of back pain or general abdominal pain, or pain specifically in their loins, sometimes going down into the groin. And this is normally caused by enlargement of the cysts and stretching of the kidneys and the nerves around the kidneys and the other structures around the kidneys that cause this pain. But sometimes it can be caused by sudden bleeding inside the kidney cysts or outside the kidney cysts, and sometimes it can be caused by infection of the cysts or the kidneys. Separate from that, infections of polycystic kidneys is quite common and is a recurrent problem, and is sometimes a reason why we will remove kidneys, which I'll talk about in a bit. As I just mentioned, bleeding into the cysts and into the urine can be a problem, and rarely people can have very heavy bleeding that can be serious enough to warrant intervention. Other sort of softer problems that people don't often realise is from their polycystic kidneys is sometimes problems with their bowels. So when the kidneys particularly get very large, there's not much space for everything else in their abdomen, and people can end up with constant nausea, very early satiety after very small amounts of fluids or food, and that can be more of a problem than people often give credit to. Obviously, the big one is kidney failure. Over time, polycystic kidney disease will result in failure of the kidneys, with over half of people by the age of 50, 55 needing some form of renal replacement therapy. We'll also ask you about family history. So because of the genetic component of this, it does usually run in families, although there is a sporadic element to it as well. People can get polycystic kidney disease with no family history at all. So then when we examine you in the clinic, what do we look at? What do we look for, and what do we find? Well, we often see abdominal distension. Your tummy's bigger than it should be. We can feel how big your kidneys are and how big your liver are, both of which are affected differently in polycystic disease. We often also will see malnutrition, and I'll talk a little bit more about that on the next slide. But another big problem with polycystic kidney disease is high blood pressure. So I talk about malnutrition. So because the kidneys are very large, people often have quite big abdomens, but they can only manage very small amounts of food, and so they can become quite malnourished. Also, the kidneys themselves can lead to you consuming more of your muscle mass than you might normally do so. And so occasionally with quite severe disease, people can have very enlarged abdomens with quite wasted arms and legs, and generally being quite malnourished, and that has its own implications.
James, just a quick question that's come in the chat from your previous slides.
Yeah.
What do you mean by N and V?
Nausea and vomiting, sorry.
Perfect. It was just a member of the audience wasn't too sure.
Nausea and vomiting. So sometimes there's so little space for your normal stomach, bowels, and the rest of your organs inside your abdomen because the kidneys have taken up all the space that people can become constantly quite nauseous. That often gets worse as the renal function deteriorates over time as well. And it's different to then tease apart what is nausea associated with the kidney function not being good enough and what is actually a space limitation from the size of the kidneys.
Thanks for answering that for them.
So how do we investigate patients? Certainly, by the time someone's been referred to us as surgeons, they would have had a lot of blood tests done to look at the function of the kidneys and their general health. We test the urine to look for whether the kidneys are leaking protein. MSU is essentially looking at whether there's blood in the urine, whether there's infection in the urine. X-rays, plain X-rays are pretty useless. There's no real use for those in polycystic kidney disease, but scans are very useful. Ultrasound scans give good information, but the problem is I don't get the pictures from those scans. Like I can't interpret those pictures very usefully. So CT scan is probably our gold standard test. It gives us as surgeons the most information about what's going on from the kidneys and the anatomy of the kidneys inside someone's abdomen. A couple of pictures, I think. So this is a typical CT scan on the right, and so this is as if someone sliced through from the front, and this is a sort of cartoon on the left. So a normal sized kidney is about the size of a big fist, I guess, and on this patient on the right here, these are some abnormal polycystic kidneys. You can just about see the normal kidney tissue underneath that's showing up a bit brighter because of the what's called contrast we use during a scan, and all these blobs here are the abnormal cysts that are formed on and around the kidneys. That's a fairly typical scan of someone with polycystic kidney disease. Unless those kidneys were causing much other problems, we'd be leaving those well alone. And we'll talk a bit more about that in time. A few more scans. This time these are slices through the body and through the abdomen. So on the top left here, this is what a normal kidney looks like. This is actually the right side. It's funny when you're looking at scans, you're looking at it from a different way. This is the right side of the patient and the left side of the patient. And this shows they're kind of shrunken and not lighting up as nicely. This is someone with probably kidney failure and diseased kidneys that have shrunken over time. And this is what they look like again in cross section. When they're polycystic, these are all the cysts from the kidneys. And sometimes we see them much, much bigger than this. And you can see that the space that it normally exists for, I'm not going to go through this slide, it's just a cartoon, but the space that normally exists for all the other organs inside our abdomen becomes smaller and smaller over time. And that's why some people get significant side effects or symptoms from their kidneys. So moving on to the sort of main part of the talk is, so when do we intervene surgically for polycystic kidneys? Well, there's two main reasons, and those are symptom related and also to facilitate transplantation. So symptoms, if people are getting recurrent infections of their cysts and of their kidneys and urinary tract, then sometimes we will consider removing the kidneys for that case. If they're getting potentially life-threatening infections, particularly, or if they are not getting on top of them with antibiotics, or if we're leading towards transplantation where there's additional risk of infection by giving someone immunosuppression, then again we may consider taking out the kidneys. Intolerant, many people with polycystic kidneys will get pain from their kidneys, or certainly discomfort. But when that's becoming really life-limiting and intolerable and people are needing high doses of painkillers, then again, sometimes we'll consider removing the kidneys. Recurrent bleeding into the urine, particularly if it's dropping people's blood count frequently, then again, we may take out the kidneys. Uncontrollable hypertension is not something we see very often, so that's uncontrollable high blood pressure. Normally we can control it, sometimes with multiple medications, but uncontrollable hypertension needing surgery is very uncommon. And then I guess you combine a lot of these things as quality of life. If people are having recurrent infections, ongoing pain, needing high dose painkillers, frequent admissions to hospital, that's all impacting on someone's quality of life. And we can certainly have a discussion then about the pros and cons of proceeding with surgery. And then lastly, when the kidneys get very big and they start extending down into the pelvis, we don't actually then have space to put a transplant kidney in. And so we would then be talking about having to remove at least one of the kidneys to make space for a kidney transplant. So what options are available to us? So nephrectomy just means removal of kidneys, and nephros meaning kidney, ectomy meaning removal. And the options available to us are removing both, so bilateral nephrectomy, removing one, unilateral, or partial, removing part of a kidney. Partial nephrectomy in the context of polycystic kidney disease is rarely done, actually. That's normally when there's a particular type of cancer of a kidney where they can safely remove just the cancer but spare some of the kidney so that it keeps functioning. There's theoretical options about draining cysts, and I'll come right at the end. I'll talk a little bit more about cyst drainage and this thing called embolization, where we actually shut off the blood supply to the kidney to try and reduce the size of it. I will briefly touch about that on that at the end. So one of the big issues in clinic when we see patients is we decided that they need a nephrectomy. So do we take out one or do we take out both? And there are separate issues associated with that, and it is a bespoke decision for each patient at the end of the day. But the main issues when we take out both kidneys is that you suddenly go to having no function at all. And depending where you were starting from, that could be a big problem. You're suddenly producing no urine output, which means fluid restriction, and most people have a litre or less of oral fluid. And you will, if you're not already on dialysis at that point, and you'll be starting it immediately in the day or two after surgery. Kidneys are involved. Kidneys are involved in several hormone pathways, and one of those is involved in blood pressure control. And so when we remove both kidneys, sometimes people can end up with serious low blood pressure afterwards, also associated with things called the adrenal glands, which can be damaged during the surgery or even removed with the kidney, with the cysts have grown around the adrenal glands. And the combination of this means that some people get very low blood pressure after surgery, which is not helped by medication, and that can have a big impact on the ability for future transplantation. And this is actually very uncommon, but it only has happened once to leave many surgeons and renal physicians a little bit scarred with their experience. But it is something I always speak to my patients about in clinic. There's a small risk of that happening. There are other hormones as well the kidney's involved with, so it's involved in vitamin D synthesis, and also something called erythropoietin, which is involved in red blood cell formation. So if you lose all your kidney function, you're losing some of these hormonal controls as well, which we manage in other ways, but it just adds to the burden of problems that patients face. When we take out just one kidney, patients often will complain of abdominal asymmetry. So if we've taken out one, it's often just because we're trying to make space for a future transplant. And so they've, by definition, then got very big polycystic kidneys, and people can feel a bit lopsided afterwards because they've still got one very large kidney in and quite a bit of space from the 5 kilo kidney that's been taken out on the other side. And that affects different people in different ways. They may still get symptoms from the other kidney in terms of all the things we just talked about. And over time, it's pretty common that the remaining kidney will continue to develop further cysts and increase in size. And in fact, I've got someone at the moment that's waiting for removal of a kidney that has grown about 5 or 6 years after transplantation. And we see that every year, people that develop problems in the remaining kidney needing further surgery. The other contentious issue is the timing of nephrectomy. So in an ideal world, it would be just when you're about to lose all kidney function and needing to start dialysis. And certainly really is when this thing called the GFR, which I haven't explained, but it's your general kidney function that we monitor over time, when it gets to less than 15. Because that's the level that is needed before we can then think about putting someone on the waiting list for transplantation. And when we're starting to make all the plans as to what type of dialysis someone will need, etc. So the other thing we also consider is waiting time to transplant. So the average waiting time in the UK at the moment for a kidney transplant is between 1 and 3 years, and there's lots of factors that affect that. Some people are very lucky and wait less than a year. Other people may wait 4, 5, or 6 years. They're the exceptions, but there are people in that situation. And so we don't want to take out someone's kidney prematurely if they're going to have to wait a long time for transplant. Likewise, if someone has a living donor that's available and has gone through all the investigation process and is ready to go, then that makes a bit more of a difference as to when we plan the kidney. And again, I'll talk about timing for transplantation after nephrectomy, in a few slides' time. So most of the nephrectomies we do are actually done pre-transplantation. And if it's purely for space, then we'll often just take out one. And when I go through the risks and complications of surgery, that's what explains a bit why we would rather, generally in surgery, less is best. The less surgery you do, the less dissection, the less potential risk of damage, and the quicker the recovery. So if it's purely for space and all the other factors are not relevant or have been discussed and patient's happy, we'll just generally take out one kidney. There have been numerous case reports of units that have trialed taking polycystic kidneys out at the same time as doing a kidney transplant. So that's sort of when there's a living donor available. It's not something that's generally done in the UK. The outcomes are variable in the published series, with quite a significant increase in transplant failure, because the polycystic nephrectomy is generally a bigger operation than the kidney transplant. So you're putting a transplant into someone that's had a very big operation and may already having some ill effects or things they have to recover from, that you normally would recover from, but then you're putting a transplant into that environment, which means that up to 3 or 4 times risk of early transplant loss. So to put that in context, around about 2 in every 100 kidneys will fail in the first couple of days after transplantation. But that goes up to 5 or 6 if you do it at the same time as a nephrectomy, which is, to us, an unacceptable increase that can be, managed by just different timing. Post-transplant, again, we will only remove the kidney if it's the remaining kidney if it's causing problems, or if they've had both kidneys left and they've been transplanted, and at some point after transplantation the polycystic kidneys cause problems, then we'll remove them. And the rate of that, depending again on which series you look at in the literature, is somewhere between 10 and 20% of patients over 10 years and will need a subsequent nephrectomy after transplant. So how do we remove them? Well, there's different techniques, and I'm not going to go into lots of detail about each one. There's the open technique, which I'll just briefly cover in a minute, and then there's a group of techniques called minimally invasive or keyhole techniques. Laparoscopic and hand-assisted laparoscopic are very similar, and then there's also more robotic reports coming out of units that are trialing these techniques. I'm not going to go much into that side of things, into the differences. They're still very much in the realm of enthusiasts, and there's pros and cons of all of these techniques. But certainly the mainstay of nephrectomy in all Western countries is open nephrectomy. But for specific questions about the minimally invasive versions, we can discuss those, and between Nick and I, we can mention our experience of that, and the sort of pros and cons of that. I mean, the bottom line is in every operation, we have to be able to get to the kidney, we have to free up the kidney from the surrounding structures, we have to safely secure the blood supply to and from the kidney, we have to divide the tube that drains the urine that connects the kidney to the bladder, which is called the ureter, and we have to get the kidney out. And that's certainly a consideration if you try and do minimally invasive operations. You've got a 25-30 centimetre kidney, it's then how to get it out, and there's different ways of managing that. But the technique ultimately depends on the surgeon, the unit, the individual patient. All of these operations are a bespoke operation and discussion with each patient, depending on their kidneys, their indications, their symptoms for doing the operation. And it's very much all about safety and doing the right operation for the right individual, rather than just say we do one way for everyone. Sorry, I couldn't find a better picture of someone without the sort of markings on. I'm just going to talk about open nephrectomy. So when we do an open nephrectomy, is it going to come? So essentially it means we have to make a cut down the middle of the abdomen. Oops. And depending on how big the kidneys are, depends on how big the cut is really. Nearly always goes from just under the breastbone to just below the tummy button. And if they're particularly massive kidneys going down to the pelvis, then it may have to go a bit further down. And then what we need to do in principle is to move the bowels. If it's on the left side, move all the bowels out of the way to the other side to be able to get to the kidneys, which sit right at the back of the abdomen. And depending on which side we're removing, depends on the risk to other structures and what we have to move out of the way. So for example, on the left here, there's this thing you can see in faint here, which is the pancreas gland, which is just on top of the kidney. And also there's a thing hiding up here called the spleen. And the liver affects the majority of the right side, although it does come over on the left. And again, that's quite important on with the right side nephrectomy. I'm not going to go too much more into the actual anatomy and how we do the operation. Now, if anyone's, I've just got some pictures of surgical pictures. If anyone is squeamish, please look away and I'll tell you when you can look back. So this is a picture of someone, this is someone's polycystic kidney at the time of surgery. It's been partially freed out from the surrounding structures, but is about to come out. This is a sort of washing up bowl-sized bowl with a kidney in to give you some size for context. That's probably about 25-30 centimeters long. And this is a pair of kidneys. So most of the polycystic kidneys we take out for symptoms and size are between, I would say, 2.5 and 8 kilos in weight. And this is a sort of fairly typical size. Sometimes if it's because of chronic infections, then we will take them out when they're smaller, and they can be, you know, well, any size at that point. In fact, one of the questions put through was, what size do they have to be for removal? Well, it depends on the indication, really. We do sometimes take out normal sized kidneys for infectious reasons, and if they have polycystic kidney disease as well, then that's just part of the decision making. So moving on to the risks of surgery. So any operation this size carries a risk of bleeding, and a small portion of people may need a blood transfusion either during or after surgery. We try and avoid blood transfusions in renal patients. Oh, sorry, you can look back now. Yeah, anyone that's looking away. Any operation, no matter how big or small, has risks of infections. So wound infections, infections that remain inside the tummy where the kidneys are removed, and also a chest infection after any general anaesthetic, no matter what the actual surgery is. These can broadly be managed with antibiotics and are rarely life-threatening, but certainly are a consideration when it's talking about risks of surgery. One of the main things that I'll talk to patients about in clinic is the risk of collateral damage, and that means damaging other things in the tummy. Now, doesn't mean to say that Nick and I are being careless during the surgery. We take great care to identify and preserve and protect all these other structures. But despite that, because of the nature of the surgery and the polycystic kidneys, other things can get damaged. And the main things are those things we've had to move out the way to get kidneys out, being the main things being the bowel, the spleen, the liver. And also nerves are sometimes something that's not actually talked about. So there can be nerves in the skin and nerves around the back of the tummy, which can behave in a different way after surgery when they're bruised or damaged. Some people, they just cause patches of numbness to the skin, but in other people, they can actually cause tingling, sort of stinging, fiery sensation, or even pain in the skin. So that can be a problem after any surgery on the abdomen, but particularly after polycystic nephrectomy. Wound problems can be an issue. So people, as I mentioned, people can get wound infections, and that can also indirectly contribute to the muscle layer of the tummy wall not healing properly, and that people can get then hernias, and hernias then need another operation, albeit a much smaller operation, but to fix a hernia requires further intervention. I mentioned earlier about low blood pressure. So particularly if both kidneys are taken, some people can get low blood pressure, and that can have a huge impact on someone. If we're planning on getting someone a kidney transplant imminently, and then the operation renders them with such a low blood pressure that actually they can't be transplanted, that is a poor outcome for everyone. As I said earlier, thankfully it's uncommon, but it's a poor outcome which needs discussing and understanding prior to surgery. So because of it's such a big operation in the tummy, and because of where the kidneys are located, it's common that nearly everyone, the bowels will go to sleep. They develop this thing called an ileus, which is a medical term that basically means that the bowel stops squeezing normally. The normal content of the bowel isn't pushed through normally. And that can last anything from 24 hours to a week or more. And if ultimately recovers, but it can slow recovery. I mean, people are in hospitals for longer while they're waiting for the bowels to start working again normally. Makes people feel a bit nauseous. They feel like they want to eat and drink because that's part of the normal recovery after an operation. But if they do eat and drink and the bowels aren't working, it can lead to worsening nausea and sometimes vomiting and needing other treatments for that. And then any operation of this size, there are general risks of getting blood clots in the legs and the lungs, having a heart attack, having a stroke. Those risks are also dependent on the health of the individual prior to surgery, and the risks are generally small, less than 1%, but they are serious risks. The general mortality rate from this operation in the literature is between 1% and 4%. And again, that depends on the starting point, really. If someone's a bit on the older side with significant heart problems or cardiovascular problems, if they have additional things like diabetes, all these things will increase someone's risk of a poor outcome after this operation. That's part of the process of planning the surgery and deciding who will and won't benefit from it, and also the consenting and discussion side of things beforehand. Recovery afterwards. So certainly here, all of our patients will go to the intensive care unit immediately afterwards. That's normally just so that people can be monitored a bit more closely for the first day or two after surgery, and they normally go back to the surgical ward. Generally, depends again whether someone's had one or both kidneys taken out, but generally people will be in hospital for somewhere between 4 and 10 days, unless there's any significant complications that need to be managed. Also depends on whether someone's just starting dialysis at that point, or whether they're already on dialysis beforehand, whether they've just had one kidney taken out, which are still trying to avoid dialysis. And it obviously depends on whether people's bowels recover, how mobile they are, how well their pain is controlled, but also factors at home. Have they got someone to help looking after them at home? Have they, do they need any extra support with the social side of things? In terms of a full recovery, in terms of back to feeling that they've no longer got any effects of the operation, it's somewhere between 2 and 6 months. And I saw someone in clinic last week who was about 7 weeks after surgery and was up doing, running several miles a day, and has now been listed on the transplant list. And that's an excellent outcome. Someone who is at that point 7 weeks after surgery, that's very rewarding for us when that happens. So other options I sort of mentioned about, so people often ask, well, can you not just drain some of these cysts? And although this picture actually shows a scan through someone's tummy, this is actually cysts in the liver, and you can see that what's happened here is someone stuck a needle into this cyst here, and then it's shrunk on this one here. So from a kidney side of things, it's rarely done. If someone's got a localized infection of one cyst that's making it essentially an abscess, then that is someone that we would definitely drain that isolated cyst. But remember, the kidneys are full of hundreds of different size cysts, and so there's no treatment that will drain, that's beneficial by draining each cyst, because they just spring up more. If there's as I said, if there's a particularly large symptomatic cyst that will clearly be benefit from drainage, then we do sometimes look at that on a case-by-case basis, but it's not a standard of care. And then lastly, embolization. So this is sort of it's been around for about 15 to 20 years since it was first described, but it's still in sort of experimental stages. I'm not aware of any units offering it routinely, certainly in the UK, but it's offered sometimes instead of surgery in certain patients, or sometimes as an adjunct to surgery, or because it's failed, we still then have to do surgery. So it's where we block off the blood supply to the kidney. And what that means in the medium and longer term is that the kidney shrinks. And so the main, therefore, indication for doing this is where we're trying to reduce the volume of the kidney for transplantation, rather than the other indications we talked about, being infection, bleeding, even sometimes the pain side of things. Even if you reduce the volume of the kidney, sometimes some of the pain type symptoms can persist after reducing the volume with embolization. It's obviously a much smaller procedure than having a nephrectomy, but pain and fever are common for about a month after surgery. Basically, you make the kidneys into dead tissue. They don't have blood supply to them, and so your body doesn't react too well to that. It produces a lot of inflammation around the kidney, and that's what causes ongoing fever and pain from the kidneys while your body's trying to sort out this abnormal sort of dead bit of tissue in your tummy that's where the blood supply has been turned off by us. So I think this is potentially promising for very selected patients. So I think, in my mind, I think patients where it's specifically for size, they've got very few symptoms from their kidneys, may be worth exploring this side of things. It's not something, again, that is routinely offered in most units in the UK, partly because the indications are slightly different. You don't get many patients with very large kidneys that have absolutely no symptoms, for example. So this is just a quick schematic of, this is a CT scan, again, looking at the front of someone's tummy. You can just about see these very large kidneys here on both sides. And this is the main blood vessel going through the tummy called the aorta, and it gives off one artery on the left-hand side here that supplies all the blood to the kidney. On the right, there's 2 arteries. And so what the radiologists have done is they've filled all of these arteries with platinum coils, and that causes all the blood supply to clot off. And then there's good evidence from Japan, where they've done quite a few hundred of these now, where after about 12 months, you get up to around about 50% reduction in the volume of the kidney. So therefore, if you purely just want a bit of space down here to put the transplant in, that potentially might be useful. If you can get this kidney to come up here and get a bit of space, then that potentially could be useful. And this is just another picture showing a similar thing. So this is a kidney on the left side at the time of the procedure. They've done their procedure. I think this is 3 months later, and then 12 months later, this one has shrunk quite dramatically. So just to summarize, so polycystic kidney disease is rare in society. I appreciate this is a niche audience, and it's probably very common amongst some people on the call, but it is common in our kidney clinic as well. We try and avoid surgery wherever possible. We are open to any treatments that can either prevent polycystic kidney disease progressing or can avoid surgery. But sometimes patients will get referred to people like Nick and I for surgery. There are various options for the surgery. Unfortunately, the evidence in the literature is poor, and very small numbers of enthusiasts trying to do one thing over another. So there's not good data to support one particular technique over another. And the timing, particularly of when to do the nephrectomy, is difficult. And it's very much down to the individual patient and what's going to be right for them. And often we'll have wider discussions with the nephrologists, other surgeons, patients, and decide when is the right time to do that. Thank you very much.
And thank you very much, James, Nick. That was a very, well, I thought it was a very clear presentation, and certainly matched to my experience. I had open surgery. Although my kidney was not that large, and I had it removed to make space, I have never had any issues with my polycystic kidney, and it was only about 21 centimeters, but and had an eventful surgery and was out on the 5th day. So that has been my experience, and sort of mirrored what you were saying post-operatively. So I said, anybody wants to ask me a question directly, I'm more than happy to talk about my recent experience.
I think there's one question just popped up there, Tess, which was about how long the wait is for this sort of surgery. I think.
Oh, well, for me, it was incredibly quick. I had hoped that my kidneys, because I'd have no problems with them at all, I've got a slight form. And I knew that I'd had a transplant 2.5 years ago, and had been told that if I needed another transplant, they would have to remove the right kidney. I had hoped it would shrink, because the literature says they can shrink, but it hadn't. And towards the end of last year, I was discussing going back on the list and a nephrectomy. I popped in January to see the surgeon. He said, "Okay, are you free in 3 weeks' time?" And I said, "Yeah, okay." But we had to delay it because of one of the strikes. So it was, for me, a rapid process. But I had already gone through the workup test for transplant, so I was declared fit in every respect. So perhaps that enabled it to happen very quickly.
I mean, I think in general for people on the call, it very much varies on your individual circumstances. And that's part of the key that I think James put across there, is that, you know, everybody needs managing individually for this. If you've not got many symptoms and we're making space and you're not yet on dialysis, it may be that we slow things down a little bit until you're close to dialysis. If you have terrible symptoms and you're getting admitted to hospital with infections or cyst ruptures, then obviously we push things forward a lot quicker and a lot more urgently. One of the big problems, I think, in this, and someone made a point in the questions, is that what happens when you've got good function but you've got terrible symptoms? And that's always a very, very difficult situation, because None of us want to put people towards dialysis quicker. And you may find in your own practice and individually that you will be put off and put off and put off. We have taken kidneys out with people with a significant amount of function, but mainly on the point that the life is so bad that, you know, they're debilitated by the kidneys. And actually, some of those people have improved whilst on dialysis, but that's not something that we like to do. And that's a very, very small number of people. The other thing that I just wanted to mention, we kind of touched on it, is the condition where people have liver disease and kidney disease. And James showed some pictures there with rather large kidneys, but a few cysts in the liver. And it's a very unusual disorder, polycystic disease, is that some patients have an enormous liver and smallish kidneys. Some people have enormous kidneys and a normal sized liver. And then some unfortunate people have an enormous liver and an enormous kidneys. And we find those patients usually need combined approach from the liver surgeons and the kidney transplant surgeons. And it may be that we end up in the situation where we have to do a combined liver kidney transplant in those patients, but that's a very small group of patients.
Yeah, the surgeon had a good look at my cysts. So I do have cysts, but I've never had any issues with my liver. I had a quick look and said he didn't feel that my liver would grow to fill the space that was available, having had the kidney out. So.
Yeah. There's a question in the pre-questions about robot-assisted surgery, and James did mention that about laparoscopic or keyhole surgery. And all these things have been tried. The majority of patients will need an open operation for a polycystic nephrectomy. And sometimes it's an up and down cut, sometimes it's across the tummy cut, depending on the distribution and size of the kidneys. Sometimes it can be a very straightforward operation. Sometimes it can be a very challenging operation, particularly if people have had a lot of infections, cyst ruptures, previous surgery or anything like that. So we normally give these operations 2 to 4, even 6 hours time in theatre. And we usually put people on the intensive care, as James has said, not necessarily because you're terribly sick, but we make a very big space in the abdomen. And if there is any just oozing of blood, if that space fills up, you can have 2-3 litres of blood collect overnight without someone noticing. Will put you in a particularly precarious position. So we like all of that to be monitored on an ongoing process, and that's the reason we do that. Are there any other questions coming through?
There's some more coming in, so if maybe one of you wants to have a quick look. We know so many of our community end up with 3 kidneys in there. They're 2 natives and they're newly transplanted ones. There's been quite a few people asking about if afterwards a native has to come out, is there any risk to that so treasured and loved transplanted kidney?
Yes, part of the reason why I said we are very reluctant to remove polycystic kidneys after transplant is not, well, we don't like doing operations unnecessarily, but there is a risk to the transplanted kidney that needs careful discussion. So it's a big operation. There are risks of bleeding and needing transfusions and of low blood pressure. And the transplant kidneys particularly don't like low blood pressure. They don't like high blood pressure either, which is why we go on and on about blood pressure after transplantation in the clinics. But by making someone relatively unstable or unwell, by having a big polycystic nephrectomy operation, there's a theoretical risk that the transplant kidney can be affected by that. It's not uncommon that the transplant function will just deteriorate slightly for a few days and then normally recovers back to where it was as a result of having such a big operation. There's a small theoretical risk if someone has a blood transfusion that they can develop extra antibodies, which again could lead to rejection of the transplant kidney. So it's not a decision we take lightly, having to do a polycystic nephrectomy when someone's got a good functioning kidney transplant, and we're trying to put someone off that unless there was significant, indication to do so.
Thank you for that. And I'll always say the jury's out. So many people say PKD kidneys can shrink when they're no longer functioning and you have that new transplant in there. What is the kind of statistics on those PKD kidneys shrinking in the long term?
I've never seen it. This is the honest answer. I've seen kidneys become asymptomatic, and patients who've had problems before and then not run into problems after we've transplanted them and they feel better. But I've never seen kidneys actually shrink without any intervention. So we see a lot of patients who have failed kidneys, been on dialysis for a while and still have enormous polycystic kidneys. And it's the nature of the disease, really. The cysts that we see are full of fluid, and that fluid's been there for many years. And if that's been infected, that's fairly unpleasant fluid as well. And that doesn't just disappear. The thing that James mentioned about embolization is pretty, in my reading, is still fairly experimental and probably not appropriate for every patient, on terms of if you do have infected material in there and then you remove the blood supply, you can run the risk of causing a lot more problems. So sometimes it's a matter of just getting rid of the diseased tissue.
Yeah.
It's important to remember that the disease is in the kidney and doesn't occur in the transplant kidney afterwards.
Yeah.
And a lot of people don't quite get that will I get polycystic disease back in my transplant kidney? That's a no, it's because of the disease of the actual kidney tissue.
I think we have to recognise our bias here as well, and that we only see patients referred back to us because of a problem with their polycystic kidneys. All the other patients that we've transplanted that had polycystic kidney disease that never needed surgery managed, by the parent nephrology teams, and we'd obviously never see many of those patients again. So certainly we only see patients back on our clinic that have now got newly problematic polycystic kidneys after transplantation. So there is an inherent bias there from us.
But again, if there is a reluctance to have, to not take kidneys out because someone's got to work in transplant, if that is because the kidneys are symptomatic, that's probably not right. And we've taken many kidneys out post-transplant because the idea of a transplant is to get people back to a good quality of life. And, if people they're off dialysis, but they've got a terrible quality of life because of back pain, infections, in hospital with ruptures, etc., the best thing to do is get rid of that underlying problem, which is the polycystic kidneys. And some of those risks are around being nil by mouth or own surgery, having to give some of the immunosuppression drugs, but they're all things that we can manage. So if you do need your kidneys out, that is something that should happen, I think.
Lovely. And there's some questions coming in the chat about, would you manage without dialysis with one kidney? And if you had 10% function and one was removed, would there be any residual function left to keep you off dialysis?
That's a great question. It's a great question, and we get a bit nervous if someone's sort of got a GFR of about 15. We normally start people on dialysis around about 10 or below. If we take one of those kidneys out, do we half it and they end up at 7? It's not always the case, and there may be some residual function that recovers, but the likelihood of accelerating towards dialysis is increased if we take one of those kidneys out, certainly. It's not easy to do split function on kidneys and see which is the better functioning kidney. We can try that, but the tests that are done don't work very well with poorly perfused cysts and things like that. So it's often we take the symptomatic kidney out if we're only taking one kidney out and someone's pre-dialysis. We might go back in later and take the other kidney out if that's causing further problems.
And just following on from that, in the chat, someone's asking, how do you decide which kidney to remove if you're removing one?
Again, same thing. It's usually the symptomatic kidney or the larger kidney. If they're both about equal and it's for size, we will often go on the left side just because that's away from the liver, but it's not a said that we definitely go on one side or the other. It's an individual patient basis. Back to what James said, if we're taking 2 kidneys out, what we'll often tell patients, because it's such a big operation, is that we will plan on taking 1 kidney out to start with, and then we'll often have a pause when we've taken one of the kidneys out, make sure that everything's stabilized, everything's safe before we proceed to the next kidney. And there have been times where we've kind of stopped halfway through the operation and said, it's only safe really to take 1 kidney out in this circumstance, and we'll come back another day to do the other one. So that is one of those preemptive things that we say. Usually we are able to get both kidneys out if we plan to.
Yeah, I'm aware that we've got a hand up in the audience there. Jane, do you maybe want to pop on your mic there?
Hi, thanks, Susan. Can you hear me?
Yes.
Yeah.
Yeah, I'm curious to know if, in the case of excessively large PKD kidneys, whether you've ever encountered a situation where it can't be removed, or one or both can't be removed because they've adhered to surrounding organs?
Yeah, so you kind of get to the point where you're committed. Once you've started dividing things, it has to come out to some extent. There was a recent situation where there was a very, very inflamed stuck kidney that we had to leave a bit of cyst wall behind because that was going to compromise other tissues. There are other kidneys that have stuck onto other organs, such as James mentioned, the spleen, where we've had to take the spleen out with the kidney alongside it. So what we wouldn't want to do is open up and then have to say, sorry, we can't do it, and close up again. We've usually got enough tests and things like that by then. Some of these operations are a lot more challenging than other operations. And usually at the end of this, the next day, I've spoken to James recently about a case we did, and neither of us could move our shoulders the next day because we'd spent 6 hours heaving up huge weight kidneys, trying to get them out. And that was just a matter of just being extra careful and taking it very slow and a long operation. But I think it would be highly unlikely to find yourself like, for example, with cancer operations, where sometimes you go in and you just think this is something that can't be done. I'm not aware of a polycystic nephrectomy that we've had to abandon the procedure halfway through.
No, it's unlikely.
Well, that's interesting, because all the photographs you see of kidneys post nephrectomy all look as though they've come out very cleanly.
So the interesting thing with that is that the kidneys are surrounded by a capsule, which is a bit like being wrapped in cling film. And what we often do is go inside that cling film. So those cysts would normally have another layer over the top, and we go inside that cling film. And if there's not been lots of infection, it actually pushes off quite nicely and gives us a nice, clean-looking kidney. The photos James showed were big, but not particularly unpleasant. Sometimes we find these things that are white and fibrous and scarred, and then we have to, don't want to use a nasty phrase at lunchtime, but have to carve them out basically, and use a variety of techniques to get those out, which is not always the easiest thing to do. But some kidneys do just lift out and scoop out. As I used to say in one of the talks, I think there's a very satisfying noise where your hand goes down and it sort of makes a noise. But
so like
everyone off their lunch, sorry.
Yeah, it sounds like a birthing experience, but yeah, thanks for that.
It's very similar, very similar.
Could I just,
now that I've been through that,
I just replied to one of the comments. Sorry, so Alison Keynes just put a couple of comments in. So I had I'm just replying directly to you. So I had some emails from Dr. Stringer. I think you're booked into one of my clinics imminently. The actual wait for nephrectomy is 2 or 3 months here at the moment in Kiwi. So I just noticed you put a couple of comments in. So that's directly at Alison Keynes. I think you're in my clinic imminently. Sorry.
Right, we've got 5 minutes to go, so I don't know if there's any burning questions that anybody wants to pop into the chat, or alternatively, they can raise their hand if they wish to ask in person. For those of you perhaps who are new to raising your hand in a meeting, on your screen you'll see there's a little reactions icon. It's a smiley face. You click on that, it offers you the facility to raise your hand.
I thought I might just give everybody a couple of practical tips, actually, since it's fresh for me. And I would if you are discussing a nephrectomy, do ask for patient leaflet on how to prepare for major abdominal surgery and how to recover afterwards. Using there are sort of guidelines, fairly standard. The type of similar to the guidelines that might be used. I think that the guidelines are actually derived from hysterectomy surgery, and I found them very helpful. So I prepared myself by doing active breathing beforehand and a few other exercises, and I was keeping my general fitness up. But then post, for those of you who've been through transplant, you'll know that you're encouraged to do mobility exercises, wriggling your ankles and stretching your legs and so on and so forth. But the exercises for post-abdominal are very helpful and give you the idea of what to do on day 1, day 2, and also in particular because if you've had open surgery, it's not you have to be extremely more careful about picking up weight. So nothing more than the size of a kettle, I was told. So, but if your hospital does not provide those, and I'm sorry to say that sometimes they're not always available, there are some on the net. Oxford University Hospitals has a very nice one, as does Guy's. They're very similar because they're following the same guidelines. But do look for those, and if you can't find anything, do contact me, and I can point you in the right direction of those patient information leaflets.
And that's a great point, actually, Tess, that these are big operations, and some elements of preparation, particularly if they're very big kidneys and people are slightly malnourished, some dietitian advice sometimes is helpful as well.
Yes, I was actually on the low side of BMI, and for a month I consumed the protein shakes to get me back up. So
I see we've got another raised hand there. Ian, if you'd like to unmute yourself, perhaps.
Hi there, can you hear me okay?
Yes.
Yeah, hi, Ian.
Hi.
Excellent. Hi, thanks very much for this. It's been really informative and useful. So I've had a transplanted kidney now for 6 years, but I noticed that obviously my abdomen is getting large. At what point is there an assessment that's done in clinic, or if would a type of scan be done to almost like preemptive to say actually these kidneys are getting pretty large, we maybe need to start thinking about them, or is it essentially you wait until a problem arises and then it's dealt with?
Sure. So if you're pre-transplant, what we tend to do at listing clinic is assess the size of the kidneys and decide whether or not there's space. If you are then on the list for a significant amount of time, we would normally reassess every year, just a clinical assessment to feel for space. And if there's a question about whether or not there's space, two things we can do. One is a repeat scan, although that doesn't always tell us whether there's space. And sometimes we've done what we call an examination under anaesthetic, because often polycystics are tender when we start prodding them. So people's abdomens tense up. So sometimes a very quick, almost deep sedation allows someone to relax, and we can feel deeply to where we're going to be putting the kidney. Often just gives us that idea whether or not we need to take the kidneys out, because we don't want to undertake this if it is possible to do without taking the kidneys out.
But I've had a transplant done, so I've had a transplant in for the last
post-transplant. We would wait basically on your guidance. If you felt you were getting enough problems that you needed your kidneys out, then that would be guided on that. We wouldn't take them out just because they're there.
Yeah. But would there be a point at which you would, if I'm saying right, I'm getting a bit of discomfort here, and obviously there's a the size of my abdomen is apparent. Would the clinic then do some sort of an assessment, an ultrasound, or
most likely
MRI,
it would be based on your symptoms and whether or not you felt you needed the kidneys out, and that would be the discussion individually with the surgeon, and overall consideration of other risk factors and things like that.
Yeah. Okay. Brilliant. Thanks very much. Really appreciate it.
Very much aware. We've got 1 minute to go. There's a question in there that's interesting from Helen. If you've had other abdominal surgery, does it make it more difficult?
Can do. So anytime anyone has abdominal surgery, the scarring happens inside, particularly between the bowel and other structures. And in some people that's negligible. You wouldn't notice it next time you had a look inside their abdomen. Other people, it can be really severe, heavy scarring, which makes any further surgery very difficult. So one thing we look out for is what operations that people have had in the past on their abdomen. And in the back of our mind, we're thinking, okay, we're expecting some extra difficulty here, and how we're going to try and minimize any risks that poses. But it's very unpredictable.
Thank you. And I think that's covered most of it. And I can see there's many comments of thanks starting to appear in that chat box. It really was a fascinating session. Thank you.
Thank you all. You're very welcome. Thank you.
Now, just to round off, we do follow up on those who've attended today to get your feedback, to see if you have gained from joining today. There's perhaps a topic you'd like to see us cover again, etc. So please give us your honest feedback. We value it, and it is anonymous, so we can't identify a occasionally people will pop a question onto a feedback sheet. Unfortunately, we can't identify who's asked the question. So if you have any questions at all, if you'd like to email myself or Tess, you will have my email address if it's a question. And please just use the feedback form purely for feedback. Now, Jane, I'm not sure, is that an old hand that's up there or a new one?
Sorry, it was me again. Yeah, I was just picking up on a point, if I understand it correctly, that you mentioned a reduction, or a loss or reduction in EPO and vitamin D and so on, post nephrectomy. And my question was, does that still occur in transplanted patients, those with a good function? Are we likely to see a reduction in EPO and Vit D?
Well, hopefully. So we hope that when someone has a transplant that we restore those functions. And that's one of the benefits of having a kidney transplant over staying on dialysis, is restoring all the function of the kidneys rather than just the filter part of it in dialysis. So if you had a nephrectomy after transplant, so long as your transplant was still working well, you shouldn't see any effect on those other hormonal functions of removing the polycystic kidneys.
Fantastic.
Thank you. And I would just echo that there's been no effect on my transplanted kidney, my transplant graft, and no effect on my medications since my nephrectomy. So thank you, everyone, and for joining us today. And thank you, huge thanks to James and Nick for presenting and answering all these questions. It's been, well, as everybody said, it's been incredibly informative, and we hope everybody's derived some value from it. Bye all.
Thank you.
See you soon.